Okay, so thank you very much, Jerry.
Oh,
This
you're
is time
welcome.
for you to step off the stage and get a drink of water and come back all charged up because we do have some questions.
Okay.
So thank you for that. I saw a number of people join into the lecture, so let me just reintroduce myself. I'm Dr. David Rawson, founder and president of this academy, the Canadian Academy of Dental Sleep Medicine, which is a short version of our long name. This is our 6th bi-weekly Wednesday webinar. Dr. Jerry Hugh came to us from Alaska tonight. I have some questions, Jerry, so hopefully you got your whistle all
Okay.
wetted up. So here's the deal, folks. Because we have so many folks tonight, we're asking for questions to be sent to me via the chat. I will read them on your behalf. This, we think, will control the time getting the questions across, and it'll give our speaker a chance to answer them. There's a message from somebody. So I'm going to start with that, but those are the rules. When we run out of written questions, if there's still time and Jerry has the energy, we'll open it to the floor, but let's start by reading the written questions. So Jerry, there's a couple here that revolve around the pharyngometer. First is, thank you very much for your excellent presentation. I appreciate the scientific approach. The question is, when you advance the jaw or increase the vertical, the literature shows us that the velopharyngeal caliber becomes larger. Since pharyngometry requires the nasal pharyngeal seal to remain intact, in other words, closed, how do you make sure that it is in fact closed when you're moving the jaw around? Please also explain what happens to the acoustic pharyngometer readings when a leak is encountered. The same phenomena happens in rhinometry. You need me to read that again, Jerry, or did you get
No,
the
I got it. So
Okay.
I'm going to kind of talk to you about, and there are limitations, and I'm glad that those things are pointed out. So first of all, when you do use the pharyngometer, it's very, very noise or sound wave sensitive. So if you have background noise and things like that, and when you don't have a sealed environment, things can definitely, yes, affect the outcome of the screen. So yes, you do sometimes have to do multiple times where you're trying to compare apples to apples. But this is what I'm trying to say when I do a pharyngometer bite. I need to have the patient in the same position. A sound source produces the wave, okay? And so the wave, when it bounces back, there's a sensor in the tube. It's the same for the rhinometer as well as for the pharyngometer. When that sensor picks up, of course, there are actually coordinates, and it's just really an XY on that, and it gives you a cross section. Since we are only looking at the cross section, if you're asking the perfect question there, but if you're looking at what it's trying to represent, there is still a kind of a guesstimation, if you will, of that cross section, right? Because they're using algorithms and math that is a little bit deeper than I'm not an engineer, but it gives you that position on a line graph of how much cross-sectional centimeters squared. So I understand that. And yes, noise and things can do that, but how I do my pharyngometer actually is quite different than several of the other either instructors or people who use pharyngometry. So I get your message, but I must say that if you look at all technology available at this juncture, okay, that the pharyngometer rhinometer is the best that we have. Now, can there be refinements? Absolutely. Can there be a lot more, metrics and landmarks that are correlated? Absolutely. So given that, we just have to rely upon the fact that we're looking at a sound source that generates these acoustic waves that's not harmful to the body, that's also not causing radiation or not, when you take a cone beam, there's radiation, but that sound wave goes, and each time it hits a landmark, it comes back. And of course, if you look at the physics of it, it kind of dissipates more and more, but it gives you that algorithm so you can see on the screen the cross section of this area. So we even have to guesstimate, because remember, it's just a line graph. So when you look at towards the left, you're okay, that's the kind of the central incisor area. When you're getting to the middle, the oral cavity, velopharynx area. So yes, it's a great question, but it is the only thing that's out there right now that also can assess behavior of the airway. Why? Because the cone beam is a static image. It's a one-time snap in time image. So if you are forward or back or air is in and out, that cone beam is only going to give you that one, but this is live dynamic. There's nothing out there right now. I wish there was something out there, but this at least gives me, if I do a Mueller's collapse over and over again in that same person, if you will, and you're doing apples to apples to apples to apples, we can see, does that position change make a difference on that minimum point?
Okay, Jerry, thank you very much. There's a couple follow-ups to this, so I want to play this and then we'll move on to other subjects. So again, sticking with the pharyngometer, second part is, in your study, was there a statistically significant difference in acoustic measurements for patients that responded to oral appliances as opposed to those who did not respond?
So it could be just luck. I did not have any non-responders really for, now I did remember one patient that didn't improve all the way under like 10 AHI or whatnot, but there was over 50%. And I did not have to do any calibration. So to answer that question on my study, and I didn't try to select, I just, the first 30 patients, because I wanted to, and also it was not industry supported. So that study had no monies or funds from Sleep Group Solutions or any company whatsoever, right? Because I really wanted to see, just by adding vertical, can I make a difference? And it did. So, and again, it's just the 30 pools and sample size. But yeah, so yeah, that's the best I can answer that.
Okay, and final supplementary, Mr. Speaker, regarding acoustic pharyngometry. Acoustic pharyngometry was first introduced to dental sleep medicine in 1998 in New Orleans. How come no one has been able to publish a study showing that measurements from pharyngometry relate to outcomes from sleep tests? Don't you think that would be a good idea before recommending it as an actual protocol in clinical practice?
I absolutely agree. But first of all, do you know how much it costs to do a randomized control? I wish I was a billionaire, or I mean, I'm also not the CEO of the company that distributes and makes the Echovision. So I agree wholeheartedly with you there. And again, what I said earlier at the beginning is that studies have to be done to move and gain the respect of board certified CPMDs, and of course dentists equally as well. But the reason why is I think, first of all, there are a lot of, there's the money issue, there's also political issue. You look at the Van der Beeken studies and the earlier studies, they actually, like for example, on vertical assessment, they said vertical doesn't even matter. Well, they used only 4mm and 14mm measurement. They never looked at anything in between. So once again, I'm talking about a 3D person that has their own individual size. You need to check increments. You need to go from different levels, make everything apples to apples, compare it. So yes, I get that. The fact that there also is done while you're awake, you're not done while you're sleeping. So that's a great question, right? But again, I would just say, kind of keep in mind, don't think that these questions haven't been asked. Eventually, I wholeheartedly believe that there are people who are going to think about, all these years when, the pharyngometer and has been around, but why aren't those studies, and why isn't there other equipment to show how things are done, at night? Well, right now, obviously, you can't use a pharyngometer at night because you're doing it live dynamic. Number two, the noise that comes from it, the acoustic sound, the sound waves, is going to be annoying as hell, right? And you have a tube that you have to hold up. I mean, I suppose if you have a robot to hold it and you have everything fixed at night while you sleep, and it gives you, recorded data. So you're on the right track. I've seen the question there, but again, I'm not defending the pharyngometer. I'm just saying I have a tool. I have all these tools in my toolbox, and it's not also to say, well, you have to do a pharyngometer bite or this bite. I do say, why not, if you do whatever bite that you love? Let's say you love the Moses bite. Well, why not take the Moses bite that you've done, put it on the pharyngometer, have the patient bite that, and see what that does. Why don't you put on the neuromuscular equipment and see how that position is for muscles versus a different? I just want people to think not just outside of the box, but to know that each tool, each thing has a purpose, and whatever can get you to the sweet spot or therapeutic position in the long run, again, in me, I feel is connected to the side effects and the reports and all those things that can be mitigated by doing the homework in advance.
Great, thank you, Jerry. So now we're going to switch to pediatric version of what we're talking about. So the question is, when is a child considered an adult sleep apnea patient? When is a child? So in other words, where's the overlap between children and adults in terms of how we look at sleep and perhaps treat them?
Well, it depends on many things. It depends on what insurance will say. It depends on what the board certified sleep MD will say. It depends on the family and what they want to do. So I know that for the most effective before a growth spurt, a lot of the orthodontia, the orthotropics are super effective. And as you get to 12, 13, 14, and the permanent dentition's in, it becomes trickier and things may take longer than they would have. But it's really, when I get that question, I really present to the patient. It's also the patient's presentation and how severe they have it. If they're coming with adenoid facies, they're mouth breathing, they have headaches, they're not performing at school, they're on Ritalin, they're on speed, they're on Adderall, they're on this, I'm going to just really have a heart-to-heart or come to Jesus moment, whatever you call it, with the patient's family and say, look, I don't think an MRD or an appliance, is really the best option here. We need to do something. We need to have intervention, right? But if someone were to come in and things seem to be fine, but when they're kind of tired and I don't know, for some reason they end up with a sleep test and they have mild sleep apnea and whatnot. Well, there's considerations at that point for MRD. But remember, MRD, as good as a therapeutic position, everything that you do, it's still kind of a super band-aid. I mean, you like, or a wheelchair, or you have to wear it, right, for it to have treatment. And if you don't wear it, it's like CPAP intolerant. You're not going to get any benefit whatsoever. And then again, because we're dynamic, your diet, your functional therapy, all those things are also combined as a whole.
So, okay, the next question probably leads into perhaps an easier answer. Have you seen stock appliances, in other words, non-customized appliances, that work well like a MyoBrace or a temporary sleep appliance? Have you seen stock appliances work as well as MyoBrace or a temporary sleep appliance?
Well, so when I do MyoBrace or Vivos or Healthy Start, all of them, I consider them pediatric, and then those actually have worked really well. But we're looking at pediatric dentition. You're still measuring the cuspids, and you're sizing them, and you're evolving in a dynamic protocol. But I have never. I've had some patients, we give these pediatric educational things for our community at the library. And sometimes, I feel so bad because some of the patients, they're either destitute or they can't afford. And so they get a boil and bite and things like that. And I would say it sometimes is kind of almost quite dangerous because I think that, when you look at the American College of Prosthodontics stance on certain appliances in the mouth and things like that aren't held at a position that's proven by the home sleep test to be therapeutic, it can actually worsen the airway. So some of the flat plane splints, some of the over-the-counter guards can actually worsen the airway. And if that's so, and you're okay with that, it could be iatrogenic. So I think it's kind of, if they're lucky, like somehow that over-the-counter makes it the perfect position that fits that. But then we're kind of throwing the dice and we're making the risk. So that's my answer.
Okay, Jerry. The next question is, what do you use to improve nasal breathing? Can people hear me okay? What do you use to improve nasal breathing?
If I find on the rhinometer and my cone beam, I use the ENT referral first. But there are some things that are over the counter and some things that can help. Of course, everyone's familiar with nasal cones and things of such sort, but also the nasal mute. Those can be beneficial as well. But definitely when there is like a deviated septum or some turbinate reduction need, I would involve the ENT. In terms of non-ENT surgical stuff, I really am an advocate for myofunctional therapy. I think all those things are important, those exercises. And if you can convince the parents, especially when you're looking at children, to do those, it really does go far.
Wonderful. Thank you. Now, just so you know, folks, I'm running out of typed questions, so send more in. I'm happy to pass them on. This is a very efficient way to handle things. So we got that. Okay, next question. When should we introduce myofunctional therapy to our adult patients? And is this something that we can learn and then teach our patients?
Absolutely. And I think so even my case, right? And some of the things are just real easy. You get a button, you get your lip muscles, auricularis, all those things that are just easy to do, or taking gum and flatten it on your palate, do it like 30 times. Those things I think it can only hurt. There's not it can only help, not hurt. I'm sorry. It can only help with nasal breathing. It can only help with long-term. If you think about this, think about the didgeridoo, right? The didgeridoo in the literature in 2004, 2006, whatever, shows that if you do that, you can really, if I'm going to go to work out at the gym and do a treadmill and do this and that, and I'm going to help my cardiovascular and my BMI and all that stuff. Well, of course, even the double-winded instruments like a oboe or a English horn, not necessarily a saxophone, but those can really help. Some of the studies were like moderate sleep apnea, down to like mild to no sleep apnea. So yes, I think mild functional therapy, didgeridoo, those things are important.
Okay, thank you. Before I move on, the chair would like to recognize Dr. Sharon Morong, who's with us in upper right-hand corner of my screen. Sharon is a newly trained sleep physician, ENT physician in Toronto, and has agreed to present to us. I think it's the first week in April. It's been on the schedule that was sent out. So we might have an interaction between Dr. Hugh and Dr. Morong when I get the questions finished. I have a commitment to answer everyone, ask every question. Okay, next question. Since it is critical that the patients be in a specific position when you take it, I presume that means a sleep study, do they need to sleep in that position? Has there been any study to demonstrate the relationship of that specific bite with the pharyngometer is correlated to nocturnal physiology? I stumbled all over that. Let me try that again. Since it is critical that the patients be in a specific position when you take it, meaning the test, do they need to sleep in that same position? In other words, okay, has there been any study to demonstrate that relationship? Does that make sense, Jerry? Second time around, it made sense to me.
Yes.
I'm glad I'm not answering it.
Of course, once again, okay, you got to look at what people are saying the Echovision is being used for versus, because there's a lot of different angles that lecturers or people say, okay? All I am saying, and I totally agree with that, because if you're sitting upright, are you sleeping upright for the rest of your life? No, you're not. And you're awake, right? And you're not asleep. I 100% agree with that. And so when you ask, has there been any literature? Obviously not, because this is the equipment as far as it has gone, period. So whether, I don't want to say it's that nobody wants to spend the money, right? Or to look at, I'm not, hey, just hang in there. There's people obviously thinking they're getting their wheels turning, and I think it's wonderful. But no, I would be the first to be aware, in my opinion, of a study such as that, which would be great, because that is, again, a good question, because there is the assumption that, hey, how do I know that position internally that I measured is going to be exactly the same during that night? See, so many things happen at night dynamically. You're in REM, your body's paralyzed, et cetera, et cetera. Of course, there's no, thing that says, yes, just because you use the pharyngometer, that's going to be perfect. And grant this, people even using the pharyngometer, they don't all have the same philosophy. Some may take a measurement with the patient, leaning forward, and then the next time they're kind of to the side. I think you have to compare apples to apples, right? But as far as the literature, no. But if I have a pharyngometer, and this is all that I have, right? It's the most advanced space shuttle that we have yet. Supposedly Elon Musk is going to have us fly to Mars, but this is the most advanced one. And this is all that I have. I'm going to use that tool, if you will, to give me perspective, just to give me some kind of, whether I do this bite or this barometric bite or blah, blah, blah. I get to have, well, what does that do while the patient's awake, alive, and dynamic. And what can I say about that? If it gives me information just like the K7 or the 10s or the muscle EMGs are so calm at this position, and then I can take that bite from a neuromuscular bite or take a pharyngometer bite or a Moses bite, and I can see what it does, it gives me information. So once again, a good example, if I would go back to the TMD patient, if they're coming in with pain and headaches and stuff like that, well, maybe since I've been really, lucky or whatever you call it at the neuromuscular bite, I may actually lean towards a neuromuscular bite. And also, I may put it on the pharyngometer to see, well, does that really make a difference in my Mueller's collapse? But I do have to compare apples to apples, oranges to oranges.
Excellent. And not to make fruit salad. Is that what you're saying?
Yes.
Okay. All right. So we're moving along. While treating sleep problems, did you find any significant changes in signs or symptoms in TMJ or structural functional changes? In other words, when you treated sleep, did you find an improvement in the presenting TMJ complaints of the same patient?
Now, when I use neuromuscular position, and if I use other things that actually really focus in on muscles, and again, it depends on, see, you could be a CR person, you could be a neuromuscular, there's just arguments everywhere, and I'm not into that, but at all, okay? It kind of drains me when I think about those things. But it can be, again, when you talk to other sets of gurus, they always say that generally when your jaw is downward and forward, when the retrodiscal tissue, the bilaminar zone is not pinched, the auriculotemporal is not blah, 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 blah. Generally, and a lot of people in the orthotropic world will really, aim for that too, say that it will help with TMD symptoms and TMJ issues and things like that. I do have to say, though, that when I think about materials and appliance selection, that when I, first of all, again, the BioGunk, when I use a very, very dense, like Control Cure PMMA material, or when I have a very precise precision milled, and I'm really respecting that position that I found gets translated or correlated, not handmade, but precision. See, I use the Trio scanner in my office, so we know that compared to a PVS impression, you're looking at 99.9997% accuracy versus a PVS impression that maybe 86, 87% in the literature, I guess, because it could distort whatnot. But those things really do matter. And when you put those things in, and again, if patients come in with TMD, the whole way I go about it is way different because they're already presenting with a whole bunch of extra red flags, if you will. And so, the position, I just spend more time with those patients.
So Jerry, if I could allow myself to add a comment to yours, because I'm not gonna write my own question. I think that's an excellent question, and I think the little bit of talking and teaching and mentoring I do, I know most GP dentists are terrified of TMD and even more terrified of sleep because they don't understand it. And so I've been the clinic director of our TMJ and Sleep Therapy Center in London for 20 years. This is all I do. And we were trained initially, you're either a TMD guy or, along comes this thing called airway. Oh my God, now what are we going to do? Well, guess what? We merged it. It's called the TMJ and Sleep Therapy Center. And for the first a number of years, I would struggle on trying to figure out, so do I think of this person as a TMD patient or a sleep patient? And guess what? It's the same person. It's the same person. Now, I know I'm a big proponent of the phonetic bite. I'm all about vertical. You mentioned it very nicely. Here's the deal, folks. Whenever I present a phonetic bite talk, most dentists pass out when they see this much space between the upper and lower teeth. And I can back it up because I have a tomogram and I know where the condyles are at all times. No one's ever died of excessive vertical. They always wake up refreshed in the morning and their jaw is better. So in answer to the question, do you see some improvement? My answer would be, if you do a good airway management, yes. I would be shocked if you don't see a good improvement in TMD. And you don't even have to say you're doing TMD. You're just doing a really good job in airway. And by the way, all the other aches and pains kind of disappeared. Dr. Morong, is there anything you'd like to add to that before we move on? I don't want to put you on the spot, but I know you've got a vital interest in this. You have to unmute yourself if...
Yes.
Oh,
hi.
Hi, Jerry. So first, thank you so much. That talk was, for me, I learned a lot. So that was amazing.
Thank you. Thank you.
And you know, what in general, what you talked about in terms of just trying to eliminate the guesswork, right? As your underlying philosophy, I am definitely on the same page with you there, because I do ENT and sleep medicine as well. And I do a procedure called drug-induced sleep endoscopy, right? So drug-induced sleep endoscopy is basically where we place the patient under sedation to try to, you know, I've heard a lot of people talking about the pharyngometer with the limitations, right? That yes, it is the only dynamic tool, but the patient is awake, they're in a seated position. We're not simulating that sleep aspect, right? And I don't think there's any one tool that can do everything. And that's why, as you said, you need to have so many different parts in your toolkit. And I think that sleep endoscopy, which I'm biased because I do sleep endoscopy, but I do think that that does provide that adjunct, right?
Yeah.
Where you do get the dynamic assessment when you simulate that sleep with sedation. So for example, you know, I have patients who come to me because they have an oral appliance and, you know, it's not working, or it is, but they still have some residual snoring or sleep apnea. We do sleep endoscopy, and then we see that, you know, let's say you did the pharyngometer and you saw that there was a reduction in the cross-sectional area at the velum, but what sleep endoscopy can show you is what type of obstruction is happening there, right? So for example, if you see that, yes, we do a jaw thrust maneuver and we see that, okay, the tongue base at that level, it opens up. So technically the oral appliance is working, but the velum has collapsed in. So then you have questions now of, well, you know, the dental appliance they have, if it's just in the AP dimension, should you be introducing a bite that has more of the vertical dimension, right? Should you, you know, you have that retromaxillary obstruction that's happening there. Does that patient need more? Do they need a, you know, MMA surgery? If we see at the velum that there's concentric obstruction, so it's not just AP,
Lateral,
or concentric, then you're coming into what you talked about with orthotropics, right? Is it that they need a concentric expansion to be done at that part? So from my end, you know, I see that all the tools you have, I think they're amazing. And, you know,
I'm an equipment junkie.
I think it's all about that interdisciplinary, right? Because there are questions that I cannot answer with the endoscopy, but there are lots of unanswered questions from the tools you have that can be answered with sleep endoscopy. So I just think it's amazing.
Thank you for that. Yeah, I think the endoscopy is so important. It's all, everything, that's sort of my philosophy from, you know, I just look at it. I looked at the Hong Kong tailor that really took his time and measured every part of me, and that suit just fit me so well. And I said, if I can apply that to my patient, I think at least it's the best I can do. My equipment are limited, like, you know, there's limitations of the pharyngometer right now, but if I combine them, at least I'm kind of with the times, if you will, versus, but hopefully inventions come out and other things, you know, improve. Yeah.
Thank you, Sharon. I hope I didn't damage our newly formed friendship by putting you on the spot. But
no, it's
well, thank you.
I just thought it would be timely to ask for your input because it's all kind of connected. Okay, Jerry, at least one more written question and then another request for a verbal one.
Okay.
This one refers to myofunctional therapy. Where would someone get more information on myofunctional therapy exercise that you've discussed?
I think my favorite one, and I could be biased, I like the Stanford Sleep group, Audrey Yoon, Y-O-O-N. She has YouTube and a bunch of videos, A-U-D-R-E-Y, Yoon, Y-O-O-N. And of course, there's Zagi. Zagi is really, really, when you do tongue release or frenectomies, he's very, very done certain research that says without myofunctional therapy, with myofunctional therapy, big difference in terms of long-term success when you remove ankyloglossia.
Super. Thank you very much. Now we're going to turn to verbal questions. Dr. John Viviano, who's no stranger to any of us, has asked for a couple of minutes. John?
Thank you, David.
Hi, John.
Hi, John. Thank you so much. I mean, I commend you for your commitment. And I mean, the questions on pharyngometry came from me. And after what I just heard Sharon share with us, I just want to put this on the table. I mean, I love pharyngometry. I've been a fan of pharyngometry all these years. As you know, early on, I published some work in that area, and I've actually going to be publishing something very shortly. Sharon, there's a big difference between endoscopy that you do and the pharyngometry. Okay, what you're looking at is real. You're actually physically seeing something. You're going in there, you're with drugs, putting the patient to sleep, and you're seeing what happens in the airway. Okay, with pharyngometry, a sound wave is traveling down, bouncing back, and some dumb algorithm, it's not that intelligent, is processing the information. Problem is that nasopharyngeal seal. We know with mandibular manipulation, right, the velopharynx opens up, behind the tongue gets bigger, even lower down in the airway. Schwab and others showed us that over a number of studies. So the problem with manipulating the jaw posture and using acoustic reflection to evaluate it is that nasopharyngeal seal, there's no guarantee that it's remaining intact. The reason you folks today that are using the pharyngometer use the nose clips is to try and maintain that seal. But think about it. If what we're trying to accomplish is an increase in caliber of the airway when we're moving the jaw, and we're actually accomplishing that in the velopharyngeal area, we are interfering with that seal that is mandatory in order for the acoustic wave to go down and bounce back and actually give us an accurate representation. Because what happens with acoustic reflection, whether it be rhinometry up the nose or pharyngometry down the oral airway, is if there's a leak, the sound waves propagate into both regions, bounce back, and distal to the leak, they're added together, it's cumulative. So when you see distal to the leak that the airway's gotten bigger, and it's being interpreted as the airway got bigger because we advanced the jaw or because we have a different vertical, well, this must be the place to be. But in fact, until we can absolutely assure and guarantee that that nasopharyngeal seal remains intact, we can't make that statement because we don't know if it's tainted data that we're looking at. And if there's a way to be able to ensure that nasopharyngeal seal is actually remaining intact, then you're looking at something meaningful. But to the best of my knowledge, we have no way to ensure that right now. I mean, maybe there's algorithms, there's different type of tests that can be done to monitor that, but right now that's not in play.
So John, the weakness of the pharyngometer, and I'm glad that you pointed out, yes, those algorithms are very, very old. But the point you kind of honed in on exactly is there needs to be another sound source that is not just coming out of the tube from far away. There needs to be another one that's more intraorally, and I agree with you. Then that you would be having acoustic waves starting at a different position, more on the inside, and you can see and have more assessment of that closure of that velopharyngeal area, if you will. So I totally get what you're saying, but right now, I'm just saying, like, I can't say too much, but you're right. That's where the technology goes, and how I'm using it is you're right. There's even assumptions on where that cross section really is at. I mean, you have a line graph, for heaven's sakes, on a pharyngometer, and that's all you have. You don't have like you said, a 3D real image of the dice, right? Yeah, that's a real image. I 100% agree with you there. But I also have to say that I just use pharyngometer all the time to get different line graphs and different numbers. Whether or not the area you're looking from that all the way down to the hypopharynx and the glottis is just guess, I still think that even the anterior to that still gives me an idea. For example, a very, very large tongue, that may be the issue. Well, AP may not resolve that. The vertical component of a macroglossia may have a lot to do with the success of the oral appliance. But again, you're very right in the sense that how do people make claims and how do people say certain things about certain equipment? It's not me. I think me. I rather just call the equipment for what it is, its limitations, and use whatever I can to give me an end result. Other people may say, it's like magic, like everything. But yes, they are guessing at what the points that you're talking about.
So gentlemen, since we use the word dice a few times, I think it's only appropriate that we let Dr. Morong come in and add her thoughts to this conversation.
Yeah, so for everyone, DICE is drug-induced sleep endoscopy. And no, I agree in that there are limitations to it. From my perspective, we've never been trained using the acoustic pharyngometer. If anything, we had the acoustic rhino but not the pharyngometer. But if it were to be used in any way, from my perspective, it would be a screen, right? So if Jerry, you were to refer a patient to me and show me your findings, at least it starts to put the picture together, right? And then what the endoscopy would do is would confirm, validate, negate, or at least explain some of the findings you had. To say that you'd go just based off of the pharyngometer alone, likely
And
not.
I think Sharon, this is excellent, because one of the points that he can say is maybe there could be a study that we turn in pharyngometer readings, right, to you. But I mean, if we lived in the same town, or you know what I mean, because then you can really validate that. I think that would be an easy way, especially where you're at, because you're an ENT and an MD that really get this. That can really, you know, answer some of those questions that John has. You know, and you can definitely say absolutely past the velopharyngeal part, the pharyngometer, because of the acoustic limitations of physics, cannot give you any assessments whatsoever. Or you can say, well, maybe there is something or whatever. You know, I totally understand what he's trying to say, because again, when you go down that angle, it's almost, you know, like a 90-degree angle. It's a 70 or 80, whatever degree angle, and the occlusive reflection gets more and more inaccurate as you're going further and further from the sound source, right? So I totally get that. But, and again, I do agree that new algorithms and more, I mean, we're in a day and age where, I mean, we have artificial intelligence, and, you know, our cell phones can record us all the time. I'm sure someone could come up with, you know, the math or the engineering to do so. I want to close with one comment is when you look at the antithesis of what I'm saying, and you look at all the literature that's out there on George gauge and on one-dimensional stuff, right? And then you look at all the side effects and you look at everything else versus what I'm trying to say about equipment, right? I know I don't want to say this doesn't sound mean, but please don't be cheap. Please don't, like, you know, just find the $2 George gauge with a 40-cent fork to do everything that we know is a serious medical condition. That's my main topic. And it's just like the same thing. You look at all of orthodontics, right? All of orthodontics, so much of the literature, whether you're talking about McNamara to Johnston, is all on lateral cephs. Lateral cephs are two-dimensional. We are 3D. When you grow someone, A point, B point, all of it changes. You're not measuring from the same exact. So when we have 3D evidence now, please think 3D. And I'm just trying to drive the fact that even though a lot of literature in the past say, and people rely on this, whatever, but now we're in a whole different time where technology has advanced and we could go beyond the simple George gauge.
Well, thank you, folks. It's almost 90 minutes. I think this has been a well-conducted session. No credit to myself. We had, I believe, 46 people at one point, so that's a huge increase. They obviously came to listen to you, Jerry, all the way from
Thank you, guys.
the other side of the country.
I'm just trying to figure it out myself. Thank you for everyone's comments, and thank you so much.
So just to confirm, his lecture, the whole evening has been recorded on Zoom and will be on YouTube and on our website in a couple of days.